Hello friends and welcome to the channel. I'm Dr. Mohsen Raj. I'm a DM cardiology student at All India Institute of Medical Sciences, New Delhi. With this video, we'll be starting a new series on learning the basics of electrocardiography or ECG. And as we complete the basics, we can move on to more advanced ECG interpretations. Let's hope we learn together. So starting with the basics, this particular video is going to be very basic, things you might know already, but I have to begin from the very beginning, right? So this is an ECG paper. That's a black ECG paper that you would have seen, of course. That's in fact given to you in the first year of MBBS in your physiology practicals. So as you can appreciate, this paper has some small squares, some large squares, and it's important to know this. So shown here in the picture, each large square has 5 small squares. Each small square is about 1 millimeter in length. So one large square is 5 millimeter in length. And same is true for the vertical one. Vertically, this is 1 millimeter per small square. The way an ECG machine is designed or calibrated is that by convention, it prints at a rate of 25 millimeter per second. The speed at which it writes the ECG is 25 millimeter per second, which means that 5 big squares, 5 large squares would be written in 1 second, which means that one large square is 0.20 seconds or 200 milliseconds. And each small square is 0.04 seconds or 40 milliseconds. So remember it forever. One small square, 40 milliseconds or 0.04 seconds. One large square, 200 milliseconds or 0.20 seconds. Now, vertically, this paper represents voltage, not time. Horizontal axis is time, vertical axis is voltage or the amplitude of the complexes of the electrocardiogram. So one vertical small box is 1 millimeter and 0.1 millivolts. So these 5 small squares would be 0.5 millivolts, or 2 large squares would be 1 millivolt. So this is the lesson number 1 to remember. So paper speed standard 25 millimeter per second. 5 large squares is 1 second. 1 large square is 0.20 seconds. And 1 small square is 0.04 seconds. That is to start. The second basic thing that you have to remember is the different leads of the ECG. We have 12 standard leads of ECG. We do take additional leads, but the standard, the convention is 12 standard leads. We have 6 limb leads and 6 precordial leads. So shown in the picture here are the precordial leads, which are numbered from V1 to V6. Well, it is good that if you go to the ECG room of your hospital, right once, apply these leads in a correct manner in a few patients, and you will learn the correct placement. But just to highlight, V1 is to the right of the sternum in the 4th intercostal space. V2 is to the left of the sternum in the 4th intercostal space. Then we place the lead V4 in the mid-clavicular line in the 5th intercostal space. V5 and V6 at the same level in the anterior axillary line and mid-axillary line. The electrode V3 lies between V2 and V4. So this is how we apply the precordial electrodes or the chest leads. The other are the limb leads, which are again 6 in number. 3 of them are bipolar, the lead 1, the lead 2, lead 3, and then there are these augmented leads, AVR, AVL, and AVF. Again, it's not that difficult. Just go to the ECG room once and see how these limb leads select. They'll place an electrode on your left arm, they'll place an electrode on your right arm and your left foot. And so the lead 1 is comprised of the lead that has the negative terminal connected to your right upper limb, and positive terminal with the left upper limb. Similarly, lead 2 has the negative terminal connected to the right upper limb and positive terminal connected to the left lower limb. And lead 3 is connected between left arm and left foot, the left foot being positive terminal and left upper limb being negative terminal. So these are the standard ECG leads, 6 limb leads and 6 precordial leads. The limb leads are numbered 1, 2, 3, AVR, AVL, AVF. and the precordial leads are numbered V1 to V6. The next thing that this picture, it would help you to remember that, again, this is the right arm, this is the left arm, and this point marks the left foot. Of course, it's not the left foot of this picture, but it's just to remember that they form a sort of a triangle in which lead 1 connects right arm and the left arm, directed from right arm to the left arm. So left arm is positive, so the vector is directed from right to left. Lead 2, which connects right arm and left foot, is directed from the right arm to the left foot because left foot is positive, right arm is negative. And lead 3 vector is directed from the left arm to the left foot simply because left foot is connected to the positive terminal. Okay, and this triangle, by the way, is known as Enthoven triangle. And this is a picture for you to appreciate how precordial leads capture the electrical activity of the heart in the transverse plane. So the limb leads capture the heart's electrical activity in the frontal plane. The precordial leads, in a similar fashion, capture the electrical activity of the heart in a transverse plane. So this is the frontal or coronal plane. This is the transverse or horizontal plane. Again, notice V1 to the right of sternum and the rest of the leads to the left of the sternum. Okay. Now, this is the other very important thing that you have to remember, rather memorize: hexaxial reference system. See, there is no logic behind why these numbers are positive on the downside of the picture, why these numbers are negative on the upside of the picture. This is irrational, but this is what is conventional. This is how the literature is based, and this is how we have to remember this. So remember, lead 1 points in the direction, this 0 degree. Okay, lead 2 to the plus 60 degree, AVF to plus 190 degree, lead 3 to plus 120 degree, lead AVL to minus 30 degree, lead AVR to minus 150 degree. So this hexaxial reference system, this orientation of these limb leads in the frontal plane will help you to remember in which direction the different leads are positioned. And this is important because you will learn in subsequent lectures that how the net electrical activity of the heart or the cardiac axis is directed in a particular direction. Or for that matter, any electrical signal arising from the heart is directed in which direction. You will have to interpret that with respect to these angles or these lines, these different axes that are drawn on this hexaxial reference system. So remember this, memorize this diagram. This will be helpful in all other ECG understandings. The other thing that I want you to understand is the orientation of these different leads, these limb leads and precordial leads or chest leads with respect to the left ventricle, because it will be helpful in the subsequent lectures which leads face the inferior surface of the heart, which leads face the anterior and the apical portion of the heart, and which leads face the lateral surface of the heart. And as you can remember from this picture, leads 2, 3 AVF face the heart from below. They look at the inferior surface of the heart. Lead 1 AVL look at the high lateral surface of the heart, and these leads V1 to V6 are known as anterior precordial leads because they look at the heart from the front and from the apex and from the side. So anteroseptal, anterolateral, anteroapical, and anterolateral surfaces, right? So in a way, this V1, V2, V3 looks more at the septum. These are known as anteroseptal leads. V4, V5, V6 looks at anterior and lateral surface of the left ventricle. These are known as anterolateral leads. Why there is no right ventricle in this in the bottom part of the picture? See, right ventricle is a very thin layer of muscle. So overall, that electrical activity is almost negated or cancelled out by the big electrical forces generated by the left side of the heart. In fact, it's even said that so anatomically, the right ventricle forms the anterior surface of the heart, but electrically, not anatomically, electrically, the interventricular septum is the front surface of the heart, and immediately behind that lies the left ventricle. So V1, V2, V3 are the anteroseptal leads. V4, V5, V6 are the anterolateral leads. And since in a way V1 lies to the right of the sternum and the most anteriorly positioned lead on the precordium, you might say it also represents and it also reflects the electrical activity of the right ventricle. Then another basic thing that we will cover in this lecture would be the waves and intervals. So what I want you to remember is that there are waves like P. P represents, as all of you know, depolarization of the atrium. QRS complex, which represents depolarization of the ventricle, and then an ST segment and a T wave, which represents repolarization of the ventricle. And no one is really sure how or what is the origin, the mechanism behind the origin of this U wave. That's not a part of this video anyways. So P represents atrial depolarization, QRS represents ventricular depolarization, and ST and T wave represents ventricular repolarization. I also want you to remember two intervals here, only two intervals. One is the PR interval, the other is the QT interval. Their significance we'll learn in the other videos, but PR interval is from the onset of the P to the onset of the QRS complex. From the onset of the P to the onset of the QRS complex is the PR interval, and QT interval is from the onset of the QRS complex to the end of the T. From the onset of the QRS complex to the end of the T is the QT interval. So in a way, this whole duration would be PR interval plus QT interval. That's one full cardiac cycle. Okay. And so remember the ST segment, which is from the end of the QRS complex to the onset of the T, plus the T wave together represent repolarization of the ventricle. The junction between the ST segment and the end of the S wave is known as the J point. We'll know about it in the subsequent videos. Okay. Another thing I want to cover, this is the last slide in this video. This is how we name the QRS complex. So what is a Q wave? What is an R wave? What is an S wave? Okay. And what do these capital and small letters mean? So Q wave is the first or the initial negative depolarization. Okay. The R wave is the initial or the first positive deflection of this QRS complex. So the first negative deflection of this QRS complex is Q. The first positive deflection is R. Now take a look at this. Here we don't see an initial negative deflection. So there is no Q here. But the first positive deflection will be named as the R wave. The first negative deflection after the R wave is the S wave. So this complex has an R wave, the first positive deflection, and an S wave, which is the first negative deflection after the initial R. So what are these big capitals and small capitals, the upper letters and the lower letters? See, it is based on the size of the wave. If there's a tall R, I would write a capital R. If there's a small r, I'll write a small r. Let's appreciate that. So take a look at this one. There's a big R and a small s. I've written capital R and a small s. Take a look at this picture over here. There's a small R wave and there's a deep S wave. I'll write a small r and a capital S. A complex like this one, which is a straight negative dip down, there's no R here, just a deep negative wave. This is labeled as, this is a convention, this is labeled as a QS complex. So on a similar tone, you will label this one because there's a deep Q wave, I'm writing a capital Q, and a very tall R wave, I'm writing a big R. And in this picture, a small Q and a tall R. So the point I want to make here is that these big letters and small letters you see, it is based on the height of that wave or the depth of that wave. A small wave will be a small letter. A big wave will be a capital letter. And in subsequent videos, we will cover how this ECG is actually produced, what is the electrophysiology behind the normal ECG, and the video second will cover the QRS axis. How do we determine the electrical axis of the heart on an ECG? I hope you like this video series, and do like, subscribe, and share this video. Thank you.